In this recording, I will go over Chapter 59, Dental Sealants. In this chapter, we will define dental sealants and their purpose in preventive dentistry. We'll describe ways to prevent problems with sealants, the primary cause of dental sealant retention failure, and the general storage for use of dental sealants. We'll also list the types of dental sealant materials and the precautions for dental personnel using dental sealants. Dental sealants are one of the greatest advances in modern dentistry. Even though sealants are widely available, unfortunately, many children do not get dental sealants. The purpose of dental sealants are to prevent caries in the pits and fissures of the teeth. Scientific studies have proved that properly placed dental sealants are 100% effective in preventing development of cavities in sealed tooth surfaces. So how do sealants work? A barrier is created between the vulnerable pits and fissures of the tooth and the oral environment. Saliva, which helps to remove food particles from other areas of the mouth, cannot clean these deep pits and fissures. The enamel that lies at the base of the fissures is much thinner than the rest of the tooth. As you can see in the picture on the top, bacteria has accumulated in the pit and fissures of the tooth. Also, the picture on the bottom shows how the bristles on a toothbrush cannot get into those fissures to remove plaque and debris. Pit and fissure sealants are especially useful during the caries active periods, which is generally ages 6 to 15 years, and may delay the need for an occlusal restoration unless a proximal lesion develops. Scientific research on the use of pit and fissure sealants has proved that sealants are an effective way of preventing the development of dental caries. Indications for the use of sealants are patients from the ages of 6 to 15 with teeth that are recently erupted. This is because during this period of development, caries can be very active. In certain circumstances, adults can benefit from their use, especially if they have deep pits and fissures in their molars and premolars. Some maxillary central and lateral incisors may have deep pits that should be protected by sealants. Sealants should always be a part of a patient's prevention program, along with the use of fluorides, dietary considerations, plaque control, and regular dental exams. There are many reasons that sealants shouldn't be placed. These include teeth that don't have deep pits and fissures, and apparent occlusal and interproximal decay. If the tooth has not erupted sufficiently, it is not a candidate for sealants. Soon-to-be lost primary teeth also aren't candidates for sealants. The cooperation of the patient during sealant placement is very important, and because proper placement requires a well-isolated dry field. Sealants come in a wide variety of materials. Sealants are classified by their method of polymerization, their sealant content, and their color. Polymerization is the process of changing a simple chemical into another substance containing the same elements. The major difference among sealant materials is how the materials polymerize. Self-cured materials usually set within 1 minute of application. They are supplied as a catalyst and base. When mixed, they harden quickly, so it is important to place the material before the initial stage of hardening or curing begins. Light-cured materials are available in a one-step delivery system in which the material is provided in a light-protected preloaded syringe and is ready for direct application to the teeth. There are advantages and disadvantages to self-cured sealants versus light-cured sealants. Box 59.1 on page 923 in your textbook provides a list of these advantages and disadvantages. Sealants may be clear, tinted, or opaque or white. The tinted and opaque sealants are the most popular as they are easier to see during applications and checks for retentions. Let's talk about fillers. Sealants are available as filled or unfilled resins. The filler material is used to make the sealant wear resistant. Both penetrate the fissures equally well, and there is no difference in microleakage. And microleakage is leakage between the tooth surface and the sealant materials. What you will use in a dental office will depend on your dentist. Some dentists use filled sealants because they think it has a lower wear rate on occlusal surfaces. Other dentists believe that because sealants flow deep in the pit and fissures to form a barrier, it ensures that occlusal wear is insignificant. The working times for self-cured and light-cured sealants vary. Self-cured sealants begin to polymerize within approximately 2 minutes of mixing. The operator controls the polymerization of the sealant material. That is why the vast majority of practitioners prefer light-cured sealant materials. The operator can control the time of set. The steps for placing a sealant are: first, you clean the surface to be sealed with a rubber cup and pumice. Next, you use an etchant of 37% phosphoric acid. You will hear this called etch or conditioner. The etchant roughens the surface and opens the pores in the enamel for penetration of the resin sealant. After etching, you will rinse and dry the enamel and then isolate the teeth. You can isolate using cotton rolls and dry angles. Then you'll apply the sealant material into the pits and fissures and surrounding enamel. Then you will either let it self-cure or cure it with a curing light. Finally, you will check to make sure that the sealant has adhered to the surface and check the occlusion. If the sealant is too high, you will have to have the dentist come in and adjust the occlusion. In Texas, dental assistants are not allowed to adjust occlusions using a handpiece. Moisture is the primary reason for failure of a sealant. Moisture can come from saliva, from a leaky air-water syringe, or the patient's breath. If there is moisture contamination, the sealant could be lost immediately or partially lost at a later date. Also, leakage could occur around the partially retained sealant, resulting in decay beneath the sealant. What are some of the problems that you can prevent with sealants? Let's look at etching. You must take care so the etchant does not contact adjacent teeth or soft tissue. What about a sealant that is too high? It may cause interference with the patient's bite. Articulating paper should be used to identify the high spots, and then the dentist can adjust the bite with a handpiece and an appropriate stone or burr. Sealant failures usually happen within the first 3 to 6 months of placements. That's why it is important to maintain moisture control, the leading cause of sealant failure. If you have too much sealant material, it can result in the excess material flowing into the contact areas. This will make it difficult for the patient to floss in that area. The picture shows too much sealant material. This is something that would have to be taken care of by the dentist or dental hygienist, as they are the only ones allowed to use a handpiece in the mouth in Texas. Another benefit of sealants is that some release fluoride after polymerization. This fluoride release creates a fluoride-rich layer at the base of the sealed groove. Topical fluoride shouldn't be applied immediately before sealant placement, but it may be applied immediately afterwards. Because etchant materials contain phosphoric acid, it is important to take precautions for both the patient and dental personnel involved in applying sealants. These include wearing protective eyewear when etchants are being used and to avoid contact with oral soft tissue, eyes, and skin. If there is accidental exposure, immediately flush the area with large amounts of water. If eye contact is involved, immediately rinse the eye with plenty of water and seek medical attention. Some other precautions include not using sealants on patients with known acrylic allergies. In these cases, use protective gloves and a no-touch technique, as acrylics may penetrate the gloves. If the sealant material does touch the glove, then remove and discard the glove, wash hands immediately, and re-glove. If skin contact does occur, immediately wash the exposed skin with soap and water. If accidental eye contact or prolonged contact with oral soft tissue should occur, flush with large amounts of water. Always use protective glasses when using a curing light, both patient and operator. Many curing light wands also have a light shield near the tip of the wand to protect the operator and dental assistant's eyes from the exposure to the light. Sealant material should be stored and used according to the manufacturer's instructions. Make sure you replace caps on syringes and bottles immediately after use. Do not expose the materials to light or air. Do not store the materials in proximity to eugenol-containing products. And store at room temperature. Most etchants and sealants are designed to be used at room temperature. The shelf life of most sealant products at room temperature range from 18 to 36 months. Always read and carefully follow the manufacturer's instructions. Application technique and etching times may vary between manufacturers. Moisture contamination is the primary cause of failure of sealant retention. Inadequate etching is also a factor in the loss of sealant retention. Make sure that you examine sealants at each recall visit to be certain that the sealant material has not been partially or totally lost. When dental sealants are properly placed, it is not uncommon for them to last 5 to 10 years. Please go to Blackboard Lecture Session 14 to view the video on Pitt & Fisher sealant application. If you have any questions, please email them to me or join me for my office hours on Wednesday from 7 to 8 p.m.